aspiration precaution, right? Because if I do it laying down, he's going to be at risk for all that coming back up and going right into his trachea, right? Okay. And because I just assume I could make a mess, I always put a towel down. And this is learning the hard way, having a tube feeding, the syringe come disconnected, and it all went all over the bed. So I always put a towel down on the end. The mannequin has tape all over his face and nose. This is not what you would normally see in the real world, but we have it this way because we have the end of the tube, instead of going into the mannequin, we have it going into a cylinder because we want you to actually be able to put the water in. We won't open the cans, okay? Will you give me an alcohol pad? We won't open the cans, but you will pour water. So you will do your free water, you'll pretend like you're doing your can, and then you'll do the rest of your free water, okay? So it'll actually go into something, so you can actually go through the motion of putting some liquid in there, okay? But ideally, this would go right into one of his nostrils and down into his stomach, okay? All right, so as I've gathered my supplies, and I figured out, I have everything that I need. I'm gonna check the expiration date. This is expired in 2004, but we're gonna pretend like it's good, okay? So I'm gonna say it's not expired because I wouldn't wanna give him anything that's expired. And I've got my alcohol prep that I put on top because when I'm ready to open it, I'm gonna alcohol it, okay? You can actually go ahead and do this at this step if you want, because if you don't touch it again, it remains understood to be clean. Okay, so I've cleaned the top of my can. I know it's not expired. I make my environment work for me because I don't want to have to be able to reach for anything. You can put this out if you want to. It doesn't matter. You can use a blue pad or a towel. I'll just lay this out here. Okay, so I have everything I need. This is pH strips. We're going to talk about the pH strips as well. This is your pH strips to test for gastric content, okay? All right, so I've got my towel set up. This is called a Lopez valve. This is what you're going to see most often in a clinical environment, okay? The Lopez valve, if you look, it'll have 3 arrows and it'll have off written on it. Okay, wherever the off is where nothing is coming out of. Okay, so when I go to open this, I want the arrows to be up and down so that water and feeding will flow through there. Okay, once you see them, we'll be helping you when you start practicing. And I want the off valve to be facing this way because anything that goes in here, I don't want coming out this valve right here. Does that make sense to everybody? Mm-hmm. Okay. So for right now, I've got that set. Okay, so what do you think is the first thing I do before I do anything else with the stuff on my table?
Gloves.
What do I want to, I hear check placement. What do I want to do even before that? Huh?
Put your gloves on.
Put my gloves on. Okay, what about after that? Before I check placement, what type of assessment do I want to do?
Check your teeth.
Abdominal, I heard abdominal. Somebody said abdominal. Did I hear abdominal? Look at that. I would normally wear this in the real world. We have another medium glove. Thank you. Okay. So, abdominal assessment's what I want to do first. Okay. So I'm going to listen before, I know we haven't done assessment yet, but I'm going to listen to all 4 quadrants of his bowels to see if he has active bowel sounds, or there's anything I should be concerned about. Then I'm going to look and feel. So I don't want to palpate before I listen. I always want to listen. You'll learn this in assessment. I always want to listen first and then palpate next. And I'm palpating for any distension, any pain or tenderness that might concern me with giving this tube feeding. Okay? So you'd say I performed abdominal assessment. Okay, what's the next thing I want to do?
Now placement.
Now placement. Okay, every single time you walk into a room, I am going to check placement before I put anything into the tube. Okay, even if I leave the room and I come back and I give a tube feeding and then I come back later and give medications, I still want to check placement again. Okay, what are the options for checking placement?
Insert air.
Aspirate. What are we going to do with aspirate? Aspirate contents.
And then check pH.
Check pH, so I can aspirate and check pH. That's one option. What's another one?
Air bolus.
Air bolus. Okay, what's another option? There's 3.
X-ray.
X-ray is another if none of my first 3 work. That's good. X-ray would be my last solution then. What's my third way of checking? Measurements, okay? Whenever you put in an NG tube, ours don't have this on it, but there usually is numbers. It's graduated, listed on here, marked off. And so you would have, whenever I inserted this NG tube, I would have documented, if I was the one that inserted in the chart, where on the tube it was, okay? So I might say there should be, it's at 30 millimeter, or 30, I don't know, I think they're in centimeters. Excuse me, 30 centimeters. And so I would look at this and say, oh, okay, well the mark is still the same, so that confirms that I should be still in the same place, okay? I'm not gonna use length as the only method of assessment for placement though. Now, we have pH paper out here because this is what your book teaches you, and this is what is in your steps, okay? You will have this available to you the day of checkoff, tomorrow. However, this will probably be the only time you see pH paper, the pH strip. These don't exist in the real world, and when I say real world, I mean the nursing world. Carrie's never seen one, I've never seen one. Your facility's policy is air bolus. Everywhere we go for clinical, the policy is air bolus for checking placement, okay? Your book will tell you that that's not definitive enough and accurate, but it's what's still practiced out in the real world of nursing, okay? So I put my stethoscope on, and I'm going to pull back 30 cc's of air, okay? Where's the stomach, anatomy-wise?
Upper
Left upper
left
quadrant,
quadrant.
right? Left upper quadrant, okay? So that's where I want my bell with my stethoscope to be, is left upper quadrant, okay? On him is about right in here. And then I'm going to put my syringe in, and I'm gonna be telling him, and when you are going through steps, you can go through steps with your patient. Say, I'm gonna go ahead and check placement now. We're gonna put a little bit of air in your stomach so that I can listen, okay? And then I wanna turn my valve, because if I don't turn my arrows to where they're up and down, it's not gonna allow anything to go in, okay? You can see by this, not gonna let me, it's resisting, see, it's not letting me put anything in there. But if I turn it, it'll let me put stuff in there. See? Okay, so 30 cc's of air, and you'll hear like a whooshing or a big garble sound whenever it goes in. Will you hear it on the mannequin? No. Okay, but we're gonna pretend like we hear it. So I put my stethoscope on, I'm listening for the whoosh, and you hear it on the, going through the tube, but you'll hear it in the stomach. It sounds like a big gargling or a big whooshing sound, okay? And then before I disconnect my syringe, because I put air in his stomach, what happens when we put air in our stomachs? Gassy, right? It can be painful. So I'm gonna pull, this is at the time, my goal is to pull the air back out, but I'm also pulling back for residual at this point, because I've said I confirm placement, the tube's where it should be lengthwise, I hear the whooshing sound. Now I'm gonna pull back for residual and pull that air back out, which he's getting no residuals. Which if somebody's tolerating the feeding, that's the way really it should be. You probably aren't gonna get anything back. So you're at least gonna pull back 30 cc's of air to make sure that it's not sitting in his stomach. And then you're looking for residual, which I'm gonna say he doesn't have any. Okay, and then during checkoff, we'll tell you whether he has residuals or not. Sound good? Okay. So once I've done that, and I said, okay, well I pulled the air out, there's no residuals, I turn off my valve because I don't want to leave it open, okay? But let's say that I got a little bit in the tip, like there was just a tiny bit in the tip. What am I gonna do with that? Test the pH, and also what else am I doing with it?
Biohazard.
Huh?
The back.
Putting it back, if it's just in the tip, I'm only gonna have enough to check the pH with, so I'm not gonna put that back, but I'm also gonna look at the color of it, okay? Color of the stomach contents usually is what? Maybe greenish, brown color, yellow. What color would it be if it was coming out of the lungs? Frothy, what's the other word I'm looking for? Sputum. It'll be like a clear sputum or frothy sputum. Okay. So I'm going to take what I have, what little bit in the tip I have, and I'm going to check my pH. Does anybody know what the stomach pH is?
Acidic.
Is it
3 to 4.
Less than 5.5. Okay. So less than 5.5. If I have a patient, so stomach's very acidic. If I have a patient who's on a continuous tube feeding, I'm probably not going to get a pH of less than 5.5 because tube feeding is very basic. And if it's sitting in the stomach getting continuous feeding, that's going to be what's in the stomach. And it's not going to come up as, it's going to come up greater than 5.5. Okay. The other thing is, If I'm pulling out residuals, most of your facilities will have an order to hold with a certain amount of residuals. A lot of times that's around 200. But you want to look at your orders to determine, because so if I pulled out over 200 residual, and as I did that, I'm going to put that in here. Every time I pull it out, I'm going to put it in here. I'm going to plug it back up, open up the valve again, pull back as much as I can until I cannot pull back anymore to measure how much residual I have left. Okay? Then at that point, that's whenever I'd put it all back in there. Okay? Why do we put it back in?
Stomach enzymes.
Yeah. Cause problems with the pH of the stomach, right? So I'd put it all back in if I have residual. Okay? Questions so far? Not yet? Okay. So what am I ready to do now? I've verified placement by 3 different ways. I have checked residuals. What am I gonna do now?
Flush.
Flush. Okay? So for flushing, everything's by gravity. If you pull up in your syringe and you do everything, pulling it up and pushing it in there, you're gonna lose. You're not gonna pass that skill. Okay? So we don't ever want to force anything into the stomach. Will you see that in practice sometimes? There are some nurses out there that do that. Shouldn't be done that way. Everything needs to be by gravity. In order for it to be by gravity, it cannot have the plunger in it. Okay? So at this point, I don't want to hook, well, I can hook this up. I don't have the valve open yet. I can set this here. This is the point where I want to make sure my can is open, where I can reach it, and my water is ready where I can reach it. Okay? Because I don't want to have to be moving over here or reaching over here to get something. I always make everything really close to me where I can work with it. Okay? So at this point, and if you have a Lopez valve, you don't have to do all this clamping of the tube. Okay? If you didn't have this valve on there that closed it off, you'd have to be working to clamp it too. So you get to free one of your hands up, which is kind of nice. Okay? So I have it off. And with it being off, let's say my order is for 100. So I don't want to use all 100 of this in the beginning. Okay? I'm only going to use half of it. Okay? Now, if I didn't have an order for free water, how much would I usually flush with? 30 to 50. Okay, so you can flush with 30 to 50 before and after. Okay, you always want to flush before and after, make sure it's working. Okay, so I'm just going to, and I have this closed off, so I'll be able to, I'm going to turn the measurements where I can see them, measure it out, and I'm just going to, and you can do it however you want to check off, you can do, but you can't do all of it. You got to leave at least 30 left for you to flush with afterward and check off. Okay. So see, because I have this valve closed, I'm able to measure off how much I put in here for my flush. Everybody with me? Okay. When you have this syringe in there, this is where I learned the towels are a vital piece of equipment when you're doing this. I always hold my fingers around my syringe and around my tubes. Everybody see how I'm doing that? Because if somebody coughs, or especially with the peg tube, if they cough, your syringe usually pops right off and you drop everything out all over your patient. So, and if they cough, sometimes your tube feeding will come back up through the tube. I know that's great, isn't it? So I always, if I see like they look like they're gonna cough, I'm like doing this, okay? Or turning the valve off. The peg tubes, you don't always have a valve, okay? So I'm ready to go ahead and do my flush. So I'm gonna turn my off to my red. If I raise it, what does it do? Faster. If I lower it, slower, okay? Now, once it gets through, I turn it off because I don't want any more air getting into the tube, okay, and going into the stomach. Because when I do the tube feeding, I don't want a whole bunch of air in here and getting into the stomach, okay? What would be a reason why I might lower it, make it go slower? If he's causing him pain, or if he's feeling some indigestion, then I would say, okay, let me lower it, and so that it goes a little bit slower, okay? So you flushed your stuff. Now you're gonna pretend, we're not gonna actually open this, put in your tube feeding. You can fill your tube feeding all the way up to here. And as it gets down to about here, you can keep filling it up and putting it in whenever you're actually doing it. Hopefully you guys will get a chance to do this in the clinical, because we usually have somebody at each site. And then once I'm done, all my tube feeding's gone in. I've kept it at a medium range. He's tolerated it well. I'm going to turn it off, and then I'm ready to do the rest of my water because I've measured out exactly what I need per my order, okay? So I'm gonna put the rest of my water in here. Oh, see, I didn't have my valve off. So put the rest of my water in there. it flow through. These are thick. You will have nurses ask you a question, or you'll have nurses do something. Do you know what I'm going to say, Carrie? What some nurses will do to make their feeding go faster?
I think so.
So this is really thick, and it takes forever, it feels like. It's like you're almost watching grass grow, getting this to go down through a tube, right? Now you may have a patient that has 200 mils of free water. If that's the case, then you flush before, you could put a little bit of water in there to thin it out, but you can't use extra water, and you have to have some left to flush afterwards. But you will see nurses who will have a whole cup of water like this, and they'll fill this halfway with tube feeding, and then they'll pour some water in there to thin it out so it'll go faster. But the patient's getting more free water than what's ordered. Okay, so you have to consider how much water you have to work with in order to do that. We don't teach you to do that in the clinical environment. You have to sit there and watch grass grow. Okay, so just a little bit of water out there. All right, so it's all flushed. I've turned it back off. Now I can take this out and lay this back down. What are some signs and symptoms he might exhibit when I'm done that's telling me he didn't tolerate it well? Distension, abdominal pain, nausea, might feel like throwing up, indigestion. Those might be some things that are telling me he's not tolerating it well. Before I get started and I'm checking residuals, what might tell me that he's not tolerating it well or not digesting it well?
When you have
A lot of residual, right? Because it's for some reason it's not getting digested into the system, okay? When I'm done, make sure it's off. Put your towel up. This blue one is your air vent. You won't mess with this at all, okay? Sometimes they put air through here to clear out the NG tube, but you won't mess with this, okay? You'll just be messing with this blue one right here, the little one, okay? How long do we have to leave them off when we're done?
30 minutes.
45 minutes.
Hmm?
An hour.
45 to an hour? At least an hour. I think your steps now say an hour. They used to say 30 to 60, but just to be on the safe side, we're gonna leave him up sitting up for an hour. Now, if he's on continuous feeding, how long will we leave him sitting up for? All the time, here all the time. Never gets to lay down, right? Because it's continuous, okay? With continuous feedings, this is a feeding bag. I didn't put any formula into it. I put water in there to simulate. Feeding bags, they all look different. A lot of times you'll go to facilities, all their kangaroo pumps or their feeding pumps look different. You may have a pump that has another bag that hangs here, which would be a flush bag and then a feed bag. These bags are only good for 24 hours. So that's why it's really important when you pull one out, a new one out, you label it. If I came onto shift and it wasn't labeled, what do you think I did with it? Threw it away. Unless I was on shift yesterday and I knew that it was a different one, I threw it away. If I had IV tubing and I came in and nobody labeled it with a day and I had to do another IV, I had to do IV therapy, an antibiotic, what do you think I did with the tubing? Threw it away. Because I can't vouch for whether that tubing was good or not, okay? Kangaroo pumps, these are